I guess one of the questions I always wonder about is how we as individuals and an organisation can, I suppose, enhance the psychological well-being of the patients and families that we meet on a daily basis. So the purpose of today, as Karen mentioned, is really to give an overview of the fellowship. Specifically, my interest was around cognitive behavioural therapy and how that can be adapted to palliative care. And also included in that is a training programme that exists in the UK where they train multidisciplinary staff in CPT first aid skills training. So it's distinct to, I suppose, some individuals who would use cognitive behavioural therapy on a one-to-one counselling, say, hour sessions. The concept of this programme was really about, when you're in a moment with a patient or a family member, that there may be skills within CPT that you'll be able to utilise in that particular moment, be it for the 2 minutes you have, 5 minutes or 10 minutes. And I'll hopefully give you a bit of an idea around the concepts within CPT that they have looked at, some of the research behind it, and see, I suppose, maybe is there a way forward, be it within our own organisation, if the interest was there about how to proceed with this. So firstly, I've mentioned, and Karen has mentioned, that I specifically went to St. Christopher's Hospice. I made contact initially with Dr. Catherine Mannix, who is based in Newcastle on Tyne. She's a consultant in palliative medicine and a cognitive behavioural therapist. And she's been quite involved over the last number of years in coordinating and putting a planning programme in place around the training. And she has signposted me to the training course that was happening in St. Christopher's. And as I mentioned, these are the things that we'll look at today. The fellowship itself, I suppose, really has allowed a financial bursary to enable this to happen. And I suppose the key thing of doing any kind of training or any kind of learning, I suppose, and what I found from it, is making a connection with someone else in another service who has a strong interest in this particular area. And I suppose developing that relationship so that it's not just a one-off kind of conference or a one-off visit, that resources and I suppose the experience that both may share is integrated and continues to happen. And since my visit, during my 2 visits, Kathy Byrne, who's a facilitator, and I have kind of had that email relationship, if you like, where we've passed on resources, and I suppose we would see that would continue to happen as well. The objectives of the fellowship were to really share innovative methods and mixed methods approaches. So to look at kind of some of the audio and video footage that was maybe more available in the UK within internal training programs and how we could get access to that. To develop my own skills and capacity as an educator by observing Kathy in her facilitation of the program. So the program was 3 days. It was 2 days in June and 1 day in September. And the idea was that participants attended the first 2 days, gained skills and insight into how they might include that in their practice. And then there was a 2-month break, so the 3rd day when they came back, they were able to share how they might have integrated that into their practice and challenges that may have arose for them in their practice. To gain knowledge about, they have a cognitive behavioural therapy clinic operating at St. Christopher's, but I'll mention a little later. And I also got the opportunity to meet with Sterling Morey, who was very involved with Dr. Mannix in the initial setup of the programme, and also provides the training with Kathy Byrne around CBT. So the background to CBT within the palliative care setting and where it's come from. I suppose some of you will have heard of CBT and know of CBT, cognitive behavioural therapy, and its origins mainly would have been derived, I suppose, within the mental health field. So there'd be quite a strong evidence base for it as a treatment of choice for anxiety and depression. And then the interest developed in how might CBT principles be adapted to palliative care, taking into account, I suppose, the physical illness trajectory and how fatigue, pain management, and all the other factors that we meet on a day-to-day basis could allow for some of these principles to be included. And particularly around, I suppose, Morey would have highlighted in 2013 that it's an effective intervention for managing anxiety, depression, and distressing symptoms such as pain, nausea, and insomnia in cancer patients. The other strand of it is that in doing their training, which was predominantly nursing, CNSs and nursing staff that were in the training programs, that staff and feedback was that they were able to use in their practice the first aid skills in improving emotional distress, enhanced coping with physical symptoms, changes in body image, physical ability, and reduced dysfunctional coping strategies. There was a period where training and ongoing supervision was provided for the staff who were working on these principles. The other finding from court was that it reduced the job-related stress and improved, I suppose, particularly nursing staff's experience and confidence in, when they met someone who may have spoken about being breathless, for example, they had a strategy that they could really sit and meet with the person and get an understanding of what the person was thinking and what was contributing to their fear around breathlessness, and talk it through rather than have their own assumptions about what might need to happen differently. So it could be said the same for someone maybe who isn't medication compliant. We may have views, at times that, well, if they take their medication consistently, that will alleviate, I suppose, a pain crisis, for example. But that message doesn't always, I suppose, sit so well with patients themselves. So really trying to get an understanding of what their perspective and view is on maybe why they're not taking medication is much more valuable in the long term about, I suppose, changing their maybe practice. And ultimately they coming to that consideration and solution and decision themselves, rather than us as maybe staff just maybe suggesting our own view and that advice giving. In terms of the 3-day programme that I attended, there was a broad range of the multidisciplinary team. Again, a high level of number of nursing staff working palliative care within home care inpatient. Large number of doctors as well, both consultants and registrars. Then there was social work, physio, occupational therapy, pastoral care chaplain. So quite a range. And I think 2 or 3 were also working on a phone line service actually as well. A specific service, and they were wondering how they could maybe incorporate these principles while working on the phone service. For those of you new to cognitive behavioural therapy, this is just really, I suppose, a brief outline of what it is. So the idea is that what you think and do affects how you feel. This diagram underneath, I suppose, highlights what is described as a hot cross bun. So it's a way to help formulate an understanding of CBT. So on one hand, there are a lot of screening tools and measures, such as the Hospital Anxiety Questionnaire, for example, which might elicit that someone is very anxious per se if they score high in it. But what this aims to do is really, in any one situation, pick something very, very specific. Again, it could be about the breathlessness, it could be about the medication, and really tap into what are the thoughts the person is having around it. What are the physical sensations, and particularly in our area of work, the physical sensations are quite significant. What are their emotions attached to it, and what are the behaviours? So if you had someone, for example, who was quite breathless and had a perception that breathlessness, if I don't breathe properly, I could die, just for example, the behaviours you might find is that they will sit still, they stay in one place, they might refuse visitors, refuse to move from A to B for fear that too much breath or using too much breath could contribute to this idea that they would die. The emotions could be linked to possibly fearfulness, worry, low mood, and bodily sensations, I suppose, that experience of, when they're even breathing, kind of monitoring their breathing and as a result maybe hyperventilating. So getting a better understanding of a specific scenario can really help, I suppose, the person in discussion maybe come to their own idea and understanding of what might be better. And I'll talk a little bit more about that in the context of this key skills. So within the programme, the cognitive model is just what I've discussed, and it was, I suppose, a lot of the examples used were particular to palliative care setting. The Socratic questioning is a term you may have heard of, originates from Socrates, and Christine Podesky is one of the authors who's written quite a bit about it within the CBT. The idea again is that we don't form our own assumptions as many professionals working with someone, that we, in our questions, create this kind of curiosity, this naiveness. So tell me a little bit more about it. What do you make of all of that? And the big challenge is that we don't jump in and answer something for the person or give a prescriptive idea of you should do this. And that actually can be quite a challenge for some disciplines if a lot of their training has been quite factual and that you're meant to know the answer to things, and if someone asks you something, not falling into that role of advice giving really. The other section that the model would look at is challenging negative thoughts. And there are 8 or 9 particular negative thoughts that we can understand that exist. Introduction to behavioural techniques and managing solvable and unsolvable worry. So considerations within the palliative care setting. I suppose that idea that managing solvable and unsolvable worries, there are aspects of people's thought processes that are very real for them, that it's not imagined, and that things can be very difficult. And I suppose the ultimate fear and anxiety is the fear of dying. And I guess sometimes we can't necessarily solve that or change that pathway, but what we can maybe consider is, well, what is contributing to that fear, and is that an accurate representation as to what could happen, and finding out a bit more about that. But in palliative care, we know that things can be that bad for people, and we have to appreciate and understand that. In terms of, I've just mentioned about the Socratic questioning, that was one of the really strong themes that came across on day 3 of the programme. When you may have 5 minutes, if you like, in a situation to discuss or explore something with a patient, and it was particularly from a medical and nursing perspective that it was coming from, the challenge of, at a medical level, being asked to answer something and not give an answer was really quite difficult, and it really challenged people in changing their style of communicating in some ways, in particular scenarios. And that's something, I suppose, that's just, a demand and a change and a different way of working that we'd all find challenging. Devising appropriate activities and experiments, part of the skills module would relate to, so say if someone is breathless and they're sitting and they're not moving and they're confined to their corner and they don't want to go anywhere, one of your behavioural tasks might be to include family and work on maybe them going, say an example here, going from their bed down to the chapel or going from here down to the dining room, just to see if what they think is going to happen will really happen. But with fatigue and pain combined into that equation for a lot of our patients, it's difficult sometimes to, I suppose, find the appropriate behavioural task that will deal with the situation at hand. Does that make sense?
Yeah.
And again, I suppose it's about flexibility and adaptation of the CBT model. So again, the idea and concept was that within palliative care, people may be somewhat exhausted by the medical professions and the hospitals and all the appointments that they have, that if it's a case that they require psychological intervention, introducing someone from an external service or expecting the person to go for 1-hour sessions isn't actually going to be maybe realistic. And also financial constraints play a role as well. So, and then I suppose a person's illness trajectory is also another factor. So the idea that skills might be utilised within the service that they're in that moment, that would, I suppose, maybe increase their capacity to cope in that given situation, and again going back to that, what the nursing staff found, increase their competence and skills in managing situations and supporting a patient. I guess time and energy constraints are always a factor, and this came up again on day 3, particularly as a nursing profession, if you're there and your priority is around maybe the physical care of the patient, and that has to be kind of primary, having time to maybe sit and talk through a scenario if you have a number of other patients to see and you're always juggling that balance. And just overall, I suppose I'd really just like to thank Karen and Michael and Gareth in the All Around Institute, and to Mary, Ita and Sean and colleagues here for supporting the release to attend, and to Cathy Byrne, Sterling and Dr. Catherine Mannix in Newcastle at one time. They really were quite fantastic and really invested and interested in the idea that others outside of the UK base, if you like, would have an interest in developing CBT skills training. and even, you know, in the context of the CBT clinic in particular, you know, give some guidance around that. That clinic at the moment operates particularly for patients and not carers or family members, which is, I suppose, the work that we in social work kind of balance doing, if you like. So it was a great opportunity to just share ideas really and get some guidance, and it's also influenced some of the work we were doing here. We had the Coping with Life-Limiting Illness seminars that we had set up earlier in the year, and I know Kathy now is in the process of developing something similar, so we've been able to share ideas and resources, I suppose, to improve our capacity in delivering an intervention to patients and families. So thank you.
Thank you. Thank you.